Very, very wonderful evening, my dear friends, pulmonologists across the subcontinent. This is your webinar coordinator from CCI, Dr. Vijay Kumar Chetty, senior pulmonologist from Apollo Group of Hospitals, Hyderabad. For the past 1.5 month, it's been a almost festival environment that's happening in the CCI webinars. We are discussing back to back ARDS management. We started with pathophysiology. We have came across the Babylon concept, then followed by we have discussed thoroughly what is the role of proning, awake proning, and then proning on mechanical ventilation. The basic golden rules of thumb, that is low tidal volume ventilation has been discussed thoroughly. Then followed by what is the role of various molecules like neuromuscular blockade, sedation, and lot of other pharmacotherapy has been discussed very in detail so far. Role of ECMO has also been discussed till the last series, that is fifth part. Today, it's an exciting journey. Next 1.5 hours, we have a star-studded panel who is, they are going to discuss on what are the novel therapies which are going to revolutionize the ARDS management. Some are definitely game changers which are being practiced. Some have a potential to revolutionize the management of ARDS in terms of pharmacotherapy. And in next probably 1.5 hours, my dear friends, we have Dr. Yatin Mehta. Sir is chairman of anesthesia department from Medanta, Gurugram. Sir, welcome, sir. CCI is really proud to have you, and then we look forward to listen your talk and also your moderation, moderating the panel regarding this very, very interesting topic. We also have Dr. Arnab, Bera, who is from Medica, Kolkata. Welcome, Dr. Arnab. He's a good friend of us and also very great enthusiastic academician with vast experience in ARDS management. And we have Dr. Dhaval Prajapati, who is from Karamsad, Gujarat. And incidentally, he practiced in Sri Krishna Hospital. That goes in the name of our founder chairman trustee, Krishna Anna. We also have another fantastic human being, Dr. Debasis Behera from Bhubaneswar. Welcome, Dr. Debasis. And he practiced as a senior consultant from KIMS Bhubaneswar. Due to some technical issues, Dr. Soumitra Sinha, who is one of the leading transplant pulmonologists of the country from Chennai, he is unable to join. He said he will join at the earliest. He is right now in flight. By around 8:30, 8:35, Sir will join us for the panel discussion. Meanwhile, I request Dr. Yatin Mehta, sir, to take over from here and to deliver talk and then moderate the session, entire session. And sincerely thank Zuventus for sponsoring this evening.
Thank you, Dr. Vijay Kumar. Indeed, a pleasure to be here. Chess Council is a very academically active body, and I'm told that they have 3,000 members, and for the last 10 years, they have been conducting these programs since they started. So, indeed, a pleasure to be here. 1 second, I have. Yeah, So today, for the next half an hour or so, I'm going to talk about the role of Aviptadil in ICU. And as I'm told that you have discussed in the last several meetings of the other modalities which are used for the management of ARDS, including proning and so on. So I will not touch upon those, just primarily talk about the new drugs which is on the horizon. So this I bring you greetings from Medanta, the Medicity, where I work, outskirts of New Delhi. We have 200 plus ICU beds and 42 operating rooms. So we all know. I mean, I'm not trying to sell coal to Newcastle, since this is a group of pulmonologists. But basically, we all know the story of ARDS, and primarily the problem is hypoxemic respiratory failure, which can lead later on to hypercapnic respiratory failure. Also, this is a multi factorial, and etiology can affect any system. And there is no specific pharmacological therapy, uh, which is, I mean, it's like a bacterial infection, you give a specific antibiotics, it takes care of that, but there's no specific antidote to this. And the interventions, lung protective ventilation, Dr. Vijay Kumar talked about, how to give your PEEP and so on and so forth, including ECMO and proning, has all been discussed. So let us quickly, this is more for postgraduates than for learned pulmonologists, but the whole story began by AECC definition of 1994 of ARDS. As you obviously are well aware, the ARDS first time was suspected in Vietnam during the Vietnam War, and it was called a Da Nang lung because the first cases were polytrauma, and it was in Da Nang in Vietnam. So these were the AECC definition, which stayed for a very long time, but there were certain shortcomings in this definition. The onset had to be acute, but the time frame was not specified. The PEEP was not mentioned, and pulmonary capillary wedge pressure was required. You had to rule out high filling pressures of the heart. So because of these shortcomings, in 2012, the European Society of Intensive Care Medicine came out with this Berlin definition, the consensus statement, and in which the onset had to be less than 1 week. That means acute. The PF ratio had to be less than 300. So 200, less than 200 to 300 was mild, 100 to 200 was moderate, and less than 100 was severe ARDS. But there had to be bilateral radiographic changes, opacities, and PEEP requirement was more than 5. And you had to rule out cardiac cause of pulmonary edema. Because of there were certain shortcomings in this also, because radiographic facility on the bedside may not be available in many of the developing countries, and because of that, ultrasound machine although is available and you can do an ultrasound of the lung, and blood gas machines also may not be that easily available. So you had Kigali's modification. Kigali was from Africa, East Africa, and for resource-limited countries, in 2017, the Kigali modification was introduced, which was, again, acute onset, SpO2 to FiO2. Now, this, mind you, this is SpO2, not PA2. So SpO2 to FiO2 less than 315, bilateral opacities with chest radiograph or ultrasound. PEEP, there was no requirement. And origin of pulmonary edema, the same as Berlin definition. And now it is further modified universally because so the ultrasound can replace the radiographic changes, but also you do not require a Swan-Ganz catheter, and therefore the SpO2 FiO2 has to be less than 315, or PF ratio has to be less than 300 with the saturation of less than 95. So this is where we stand. If you're taking PF ratio less than 300 is mild, and SpO2 FiO2 less than 315. The etiology of this is variable, as you can see. It can be sepsis is the commonest reason why they get it. Patient may have a bacterial sepsis, fungal sepsis, viral sepsis, aspiration, pneumonia, polytrauma, pancreatitis, burns, thoracic injuries, and so on. So they're multifactorial etiology. But despite the developments in intensive care unit, the mortality still remains pretty high worldwide. So this was a lung study, lung safe study, which is highly quoted. And in this particular study, there were 50 countries with almost 459 ICUs. The data was huge from all over the world. ARDS accounted for 10% of the admissions to the ICU. Quarter of them required mechanical ventilation, and the commonest causes were pneumonia and extrapulmonary sepsis, and followed by trauma. But the important finding in this was that for many years, the survivors had muscle weakness and fatigue. So it has a long-term implications. And this was an Indian study. PGI Chandigarh, it was a post-mortem study. Again, they found higher number of males, younger males, and prevalence was about 6% in autopsies. And the commonest causes was ARDS and sepsis, which is a little interesting. But this was an autopsy. The pathologists had done that. So I am not too concerned about the definitions. But the main thing why they were males and why they were young males was young males get the best medical treatment in India. Otherwise, elderly people, you let them go. So this was a genuine case which we had. A 58-year-old man, reformed smoker, presented to the ED with fever, cough, expectoration, difficulty in breathing, and no other major complaints. He was known hypertensive and diabetic for 15 years. Hemoglobin HbA1c was 8.5. He had transaminitis. Platelets were 35,000. ABG he was acidotic, hypercapnic, hypoxemic. ECG had sinus tachycardia. He had transaminitis. All the other topical fever profiles were negative, except that he was dengue IgM positive. And this is what the plain X-ray test looked like. So as you can see, the bilateral infiltrates and some congestion. So it was a case of dengue fever with thrombocytopenia, with LFT and lung infiltrates. Patient had hemoptysis, increasing oxygen requirement, worsening respiratory distress, and we tried NIV but didn't work, so we had to intubate him. He was mechanically initially ventilated, FiO2 50%, while receiving PEEP. 2D echo is a normal systolic function of the heart. Lung ultrasound showed the diffuse B lines, mild pleural effusion. Lung protective ventilation, including prone positioning, was attempted. Supportive care was nutrition and blood products. But patient continued to deteriorate, and PF ratio fell to less than 100 with FiO2 2.8 and with a high PEEP. ECMO was contraindicated because he had hemoptysis. So, as a desperate measure, we were in a very tight corner. The patient was very sick. We used Aviptadil. We gave it over a period of 3 days. This is the standard dose which is recommended. First day, 0.166 microgram per kilogram per hour in 10 to 12 hours. Next day, you add double the dose, and next day, you add triple the dose. So starting from the second day, there was a notable reduction in FiO2. Transition to after 5 days, we extubated the patient. We started on NIV with minimal oxygen support. This is what the chest X-ray looked like. So patient got better and got discharged. So what is Aviptadil? Next, I think for 10-15 minutes, I'll just cover that. It's a synthetic vasoactive intestinal polypeptide, and it is basically synthesized in the nervous system and mainly localized in the lungs, where it is supposed to work. Elimination half-life 1 to 2 hours, 1 to 2 minutes, so it has to be given as an infusion. And it is completely eliminated by the kidneys. This is the pathophysiology of ARDS, which you have discussed. So where does it all work? Well, it reverses the CD4 to CD8 ratio, reduces production of inflammatory cytokines by the dendritic cells, inhibits inflammatory markers, inhibits platelets activation, so microthrombi is reduced, primarily increases the surfactant productions by various mechanisms. Okay, in all the ARDS patients, surfactant is reduced. That's why the electrolysis and the pH ratio is worse. So this upregulates certain receptors and binds to primarily alveolar type 2 cells through the VPAC receptors. Okay, that is how it acts. And it also maintains the integrity of the alveolar type 1 cells, reduces apoptosis, and restores the endothelial functions and many other functions to prevent cell death. And so integrity of the endothelium is restored, surfactant is increased, and lung compliance gets better. So ultimately, it will prevent pulmonary fibrosis also. So this is the mechanism by which it acts in COVID-19. The receptors of COVID-19, the virus of COVID-19 attaches to the same receptors. And therefore, it not only reduces the sites where the virus can bind, but also reduces directly the replication of the virus in the lungs. Also, in all COVID-19 patients, which you all must have seen, there is pH ratio deteriorates, lung atelectasis happens, and then this reverses that. So this can be helpful in that. Here you can see few studies have shown in SARS-CoV-2 infections, it is the morbidity and mortality directly proportional to the VIP levels in the blood. So VIP levels are down, that means morbidity and mortality will go up. So this is where it comes into picture. The pro-inflammatory factors are reduced, SARS-CoV-2 replication is reduced, and cell death is reduced. Now, this was a radioactive study which has shown that about 70% of the administered Aviptadil, it localizes into the lungs. So various agencies have recognized this. I mean, so the several health agencies worldwide, US FDA approved it for pulmonary hypertension because it produces pulmonary vasodilatation. In 2005, European organization approved it in 2006. US FDA again, 2020 for COVID-19, it approved that. Georgia approved that again for the same thing. CDSCO in India approved it in April 2022 for COVID-19 ARDS. So what we do is, when we are using it for non-COVID ARDS, we are taking a consent from the family. Okay, and I would request whosoever, the Zuventus guys, to later on facilitate the, because it works. I'll show you that. But this is, in US, it is orphan drug designation because the numbers are not so big. It has also been approved for sarcoidosis. What is the international few studies I'll talk about? Okay. So this study was done in Stony Brooks in New York, and where you can see 8 patients, out of which who received Aviptadil, 7 patients were extubated, and 6 patients were discharged from the hospital. Okay, so this is pretty good. And inflammatory tumor necrosis factor alpha reduced in all the patients. So this was 1999, one of the earlier studies. Then this study was done in Methodist Hospital, Houston, Texas. And Aviptadil was used in 21 patients compared with 24 standard of care of now, in this patient, there was 9-fold recovery from respiratory failure with Aviptadil. Also, survival at day 60 was 81% with Aviptadil, 21% in the control. So this was a huge difference. As you can see on the graphs underneath, the WHO ordinal scale of oxygen requirement also was substantially better in patients who received Aviptadil. And this, again, was studied by Yusuf et al. From again, the same Houston Methodist Hospital. This was a pregnant female. This was the first reported case used in a pregnant female who developed COVID ARDS. And as you can see, the X-ray was very bad to begin with, and it gradually improved after 3 doses. PF ratio also was 123 to begin with. It improved to 348. Patient was discharged from the hospital, and ultimately she delivered a normal, healthy baby. So I'm not saying use it in pregnant patients because they took a separate consent and they were in a corner to use this drug. So this was a multi-center trial, a randomized controlled trial, huge number of patients, 196 patients. Survival almost doubled with Aviptadil, and interleukin 6 significantly fell. So in COVID-19, it was of benefit. Let's look at a few papers. Indian experience. So this was a paper by Diwan. Diwan has done a lot of work on this from Zuventus. So again, this was a COVID-19 study. It was a randomized controlled trial, multi-center. And they gave it a 12-hour infusion over 3 days, escalating doses, as you can see. And secondary endpoint was improvement in the WHO scale, improvement in PF ratio, and adverse events. So here you can see significant every day. The Aviptadil patient had a better WHO 7-point score. So they improved, and after 3 days, most of the patients did not require any oxygen. So there's significant improvement. And secondary endpoints also, quicker recovery, better oxygen-free state, hardly any side effects. So all the parameters were better in the patients who received Aviptadil. And this was a study of a 3-patient series, one of the earlier ones. So we had 3 patients, as you can see. One was a 24-year-old male with the PF ratio 110, community-acquired pneumonia, and AKI. We gave 3 doses of Aviptadil. On 9th day, patient was extubated and off the ventilation. The second case was a 38-year-old female. As you can see, the radiological changes, and with the PF ratio less than 100. This was dengue fever with diabetes. Again, 3 days Aviptadil. On 5th day, she was off the mechanical ventilation and switched to NIV and discharged from the hospital. And 4th, again, was a pneumonia ARDS, and 4th day, patient was extubated and then later on discharged. This was an interesting case which we had after cardiac surgery. It was published in Journal of Cardiovascular Anesthesia, a prestigious American journal. So we had a post-aortic valve which required a large number of blood transfusions the patient received, and classic ARDS picture or trolley patient had. Again, it was a fresh cardiac surgical cases. It's not very easy to put on ECMO. So we said, why not try this? So we gave Aviptadil for 3 days. PF ratio gradually improved after the second dose. Patient was extubated by 5th day and discharged from the hospital on the 10th day. And Agam Vora and other pulmonologists from all over and intensivists from all over India, they recommended the functionality is good, and more studies are required. So they recommended that. What is the posology? Well, first day you give 0.166 mics per kilo per hour. For a 60 to 70 kilo adult, I would say it is very simple to remember. You give 1 vial on the first night, 2nd vial on the 2nd night, 3rd vial, 3 vials on the 3rd night. So 1 vial, 2 vials, and 3 vials. 3 doses, 10 to 12 hours. So that is the simplest way to remember that. And this is the dose which has been recommended both to Yusuf and Dewan. So that's what you do. Why do you do this escalating doses? Primarily because it can produce vasodilatation, and this is just to reduce that. Side effects are hardly anything. It's an endogenous peptide. So side effects, although it is synthetic, what we administer to the patient. So if the patient may have hypersensitivity like to anything else, but it is a vasodilator. So it can produce hypotension, flushing, which may be cutaneous or facial, and infusion-related reactions. And as by the name suggests, it can produce diarrhea. So regular monitoring of blood pressure, most of the times, if the blood pressure drops, you give some IV fluid, stop the infusion temporarily, it comes up. The current status we do, it is not present in any guidelines at the moment. It will come in future, I hope. We require more paper research to establish this and the DCGI permission for use in non-COVID ARDS. So I thank you very much for your attention. And I think that we'll move on to the panel discussion. I can see Dr. Prajapati is also joined. 1 second.
Yes, sir.
I'm trying to stop sharing, but we can do that? Yeah. Okay. So we can proceed with the, yeah, sure. Okay. Okay. So except Dr. Sinha, the rest of the quorum is complete. So I hope I have given the right amount of preamble to the topic. So let us begin. And at any stage, any of you want to add something, you are most welcome to do that. Okay. So this is an informal discussion. So Dr. Behera is the first one. Which definition of ARDS do you follow, Dr. Behera?
Good evening, sir. Sir, thanks for this nice question. First, I would like to congratulate you, sir, for this beautiful presentation. So you have very beautifully described all the definition of ARDS, starting from the Berlin definition to Kigali to the ARDS new global definition. So presently, we are all using this ARDS new global definition. The time to installation, we all know that it is up to 7 days of the known risk factors. And pulmonary edema, which is not explained by cardiogenic edema or any intravascular volume overload. And radiological features, bilateral infiltrates in the chest X-ray or CT, or lung ultrasound, which is added in the ARDS new global definition, which was not there in ARDS Berlin definition. Because in some centers, this HRCT thorax is not available. So in centers in which ultrasound machine is available and you are trained enough to see any evidence of consultation, B lines, then of course you can stamp it as a case of ARDS, which is not explained by nodules, pleural effusion, or atelectasis. And coming to hypoxemia, the PO to FiO2 ratio was used previously. But what we have seen during the COVID era, a lot of patients were being treated with HFNC. And in some centers, ABG is not available. So to cover that area, they have added in the hypoxemic era, the SpO2 to FiO2 ratio. And when the HFN now flow rate is more than 30. So 201 to 300, it is mild ARDS, 101 to 200, it is moderate, and less than 100, it is severe ARDS. So there are two modifications in the ARDS new global definition. One is the addition of lung ultrasound, the place in where HRCT thorax is not available, and the addition of HFNO and pulse oximetry, not only ABG. So this is the most recent definition that we are using in our day-to-day practice.
Thank you, Dr. Behera. I think you nicely explained, even for the postgraduates, what was the Kigali modification and what is the global definition now, which should be followed. So, Dr. Bera, what ventilator settings do you follow?
Yes, sir. Thank you.
I am deliberately not restricting the discussion only on Aviptadil. Okay, this is a picture, holistic picture of. So that's why I'm getting into the okay.
Okay, sir. So, despite there are various studies on, there are multiple novel therapies, but I think the primary thing is which is actually decreasing the mortality and which is, I think, globally acceptable. That is the low tidal volume strategy in ventilator setting. Okay, so definitely you have to use 6 ml per kg of idle predicted body weight, and important part is another important part is the tidal volume, and another important part is the PEEP. So there is in ARDS protocol there's two table also, low PEEP and high PEEP table. So we can use the low PEEP table for for the indirect cause, and for direct cause you can do the high PEEP table. But personalized medicine ARDS management is now in a concept. We can target there are certain things which you have to think of during when you are ventilating a ARDS patients. Definitely the first important point is you have to maintain the oxygenation, and second equally important point is you have to prevent the VILI, that is the ventilator induced lung injury. For that what we have, so we can maintain a plateau pressure less than 30. Okay, we can use a driving pressure to manage our PEEP. So if the P plat minus PEEP is less than 15, so there is a decreased chance of mortality, and accordingly we can modify the PEEP using the driving pressure. You can also use the transpulmonary pressure, but the esophageal probe is not available everywhere. So basically low tidal volume strategy along with a PEEP, targeting the driving pressure less than 15 would be our target, and accordingly that you have to maintain the oxygenation around 90-92%. That is the initial thing.
Thank you, Dr. Bera. Nicely explained. So I can see Dr. Prajapati has joined. So thank you, Dhaval. Welcome.
Yes, sir. Thank you.
So do you follow Dhaval? Do you follow the PEEP table?
Sir, if we see the ARDS as such, it's a heterogeneous disease, and there is a heterogeneous distribution of the disease. And if we see, and many literature also showing that the non-aerated lung tissue varies widely from 5% to 75%. And if we see the anatomical extent also is variable, where the potentially recruitable lung is there. So if we see the recruitable lung, that is benefit, and non-recruitable lung is very harmful. And if we fix our PEEP as per the table, then it is not like one PEEP can fit to all the patients. So we have to individualize our PEEP titration as per the patient. And there are low PEEP and high PEEP as per the ARDS net protocol. There is a FiO2 along with the high PEEP versus low PEEP. And if we see based on the PF ratio, whenever there is a PF ratio more than 200 or 150, then we always go with the low PEEP. And whenever there is a severe ARDS less than 100 PF ratio, then we have to go with the high PEEP, and as much as low FiO2, because more than 60% FiO2 per se, it is toxic for the our body. And whenever our target should be PO2 more than 60. So with the FiO2, minimum FiO2 with the high PEEP when there is a severe ARDS. So in the low PF ratio, we should go ahead with the high PEEP initially with the 50% FiO2, directly starting with the 15 PEEP, and then so on with the 100% FiO2. With the maximum, you can go ahead with the 20 to 24 PEEP. So we usually follow not the only one criteria for the titration of the PEEP, but we can also go ahead with the driving pressure, as well as if we can measure the compliance of the lung, then maximum compliance would be the best where we can give the PEEP, right? There are other criteria also, like low inflation point, but it is not always possible because the opening pressure and the closing pressure of the alveoli would be different, and not every graph or curve, that is pressure volume curve, will show the low inflation point, because it's a heterogeneous disease. Only homogeneous, because it's a average of all the PV curve, which shows your lower inflation point. So it is not always true for the every patient, because it's a low inflation point is not, sometimes we over using the PEEP if we consider the low inflation point. So we have to consider the multiple parameters.
Thank you, Dhaval. Very nicely explained. And again, for the postgraduates, Dr. Gattinoni, Professor Gattinoni has done a lot of work. He recently passed away on ARDS and ventilatory strategies, and doing the CT scans and showing the attenuated lungs and non-attenuated lungs, and he's done a lot of work on this. So, okay. Now, Dr. Behera, what are the pharmaceutical agents have you used in ARDS? Dr. Behera, you're on mute. Please unmute yourself. Yeah.
Okay. Sir, we all know that the cornerstone of treatment in ARDS management is, of course, we have to treat the primary cause and the adequate ventilator setting, as Sir has already beautifully described, that is low tidal volume, high PEEP ventilator strategy. And if required, we can go for plain ventilation. Now, coming to pharmacological therapy, there are 2 to 3 pharmacological therapy that we often use in our day-to-day practice. One is steroid. So after this DEXA study of COVID-19, the role of steroid is quite important in some parts of the ARDS. It is highly effective because of its anti-inflammatory action, sir. And it has been shown that it reduces the duration of the inverse mechanical ventilation and sometimes mortality benefit. But the caveats being is that the duration, dose, and the optimal which kind of steroid you should use is not clear yet. And you should be very cautious in using steroid which are chronically immunocompromised, like patients who are on immunosuppressions, patients who are tuberculosis. So in those group of patients, you should use the steroids very cautiously. And of course, if it has been clearly seen that if you are using steroids, when the duration of invasive mechanical ventilation is more than 14 days, it causes more harm rather than any benefit. So steroid is useful in ARDS if you can use it at a good time with a...
See, I'll just come in 1 second. Dr. Behera, let me just interrupt you here. Again, for the postgraduates, the role of steroids in viral pneumonias is fine. The role of steroids in bacterial pneumonias is a little debatable. I mean, community-acquired pneumonia, yes, but hospital-acquired pneumonias, one would really hesitate to use the steroids. And again, for the postgraduates, when you use steroids, don't use very high doses of steroids, as shown in the COVID studies. Okay? Dexamethasone, 4 to 6 milligram is sufficient.
Sufficient. Then there is a role of these neuromuscular blocking agents, because in ARDS patients in which we are using high PEEP and severe ARDS, previously it has a mortality benefit as per the Accuracy trial, but whenever this ROSE trial came, it has shown no benefit. So it is a very debatable thing whether you have to use this steroid or not. But practically, in our settings, neuromuscular blocking agents are not routinely recommended. We can use to tackle asynchrony when it is not controlled adequately with sedation. So these 2 pharmacotherapy agents we often use in our ARDS patient. Rest all are ventilator settings and treat the primary cause.
And obviously, if it is sepsis, then adequate bacterial or antifungal, whatever you use, so that would be.
And this has to be in all the issues that we have to.
Yeah. Okay. So, Dr. Bera, coming to you, have you used Aviptadil?
Sir, I don't have so much vast experience like you in using Aviptadil, sir. So I have used in only one case during this COVID-19 pandemic, and I can tell the story. I think I had lots of time to tell my story of one use of Aviptadil. So basically, that was I think 28 to 30-year-old male patient, morbidly obese and single child. So a small shop owner doing small business kind of thing, and he was admitted like 2 days of fever, 2 days of fever, and tested COVID-19 positive outside, and admitted in our hospital and with a breathing problem. So because he was having breathing problem, that's why he was admitted in the hospital, and that admitted at almost middle of the night, and at morning. When I was in the round, his oxygen was actually going very badly downwards, and we have started on HFNO at that time. And we have used that. We have already started that remdesivir, the steroids, anticoagulant, which is the standard protocols. And the procalcitonin level was normal. IL-6 level was quite high. So we have given us 1 dose of tocilizumab also at that point of time. And in the night, his condition actually deteriorated a lot and ultimately landed up in mechanical ventilation. and with a very high PEEP and kind of thing, and his oxygenation was still not maintaining. So because we have a very good ECMO support, at the time of COVID-19, we have run almost 30 ECMOs at a single point of time in Kolkata in our hospital. So definitely we are actually refer the patient for ECMO. But his father was a kind of school teacher, middle class family, so he was not able to actually afford the ECMO support. And then a young chap, single child, so we are thinking what we can do next. So that at that time we thought is let's give a trial of Aviptadil, and we have started the Aviptadil at the same night. Okay, and we have given for 3 days, and the patient was extubated. We have given 3 days. Then after 4 days of completion of Aviptadil, the patient was extubated, and another I think 4 or 5 days before he got discharged also. I don't know, sir, that actually what Aviptadil used or the standard remdesivir or steroid which have worked, we don't
No,
know.
obviously the other drugs were also working.
Yeah,
Yeah.
but
It
this
is
is
not
only my
like a
one
magic
single
drug.
experience with
What
Aviptadil.
I, what, yeah. So what I find is that some patients will not get better, but
Yes,
when they respond, the responders, you see dramatic improvement.
yes,
There is no question about that.
yes.
Dr. Prajapati, would you like to discuss some of your cases or some experience?
Yes, sir. We have used in a 5 or 6 patient Aviptadil, mainly in the post-viral influenza ARDS patient. And we have mixed response. Not all the patient have benefited, but maybe because we as a tertiary care center, we usually received patient of like referred patients. So most probably they are like more than 7 to 8 days old and in a gray zone. So they were not benefited much, but yes, definitely 4 patient out of I think from 6 patient we have post influenza and one is COVID. So they have benefited, and we get benefit in the form of like the oxygenation requirement has decreased dramatically after 3 days of therapy, and the ultimately requirement of ventilation and patient successfully extubated. One patient has died because of the secondary sepsis afterwards, but the rest of the 3 have survived good.
So I think what I believe is that there is absolutely no real harm in giving it because the drug is not very expensive. First
Yes.
of all, there are hardly any side effects because you are giving it in 10-12 hours infusion. So hypotension also you really don't see. I haven't seen any flushing and all that, but it can happen theoretically. And if a patient in the ICU gets a bit of diarrhea, you're not that worried unless it is C. difficile. So many of them are constipated. So it's not a big deal to if they get a bit of diarrhea. But when it works quite well. And also, several published studies have shown that sicker the patient, better its effect. So mechanically ventilated patients show better results, I mean, in terms of statistical numbers, than the mild sort of patients. But I see no reason why not to use it in mild patients also, because it's very difficult to predict which patient is going to deteriorate in ARDS. So if it's mild, that doesn't mean he's going to stay mild. He can deteriorate. Yes, please. Yeah, Dhaval.
Yes, sir. So the regarding the mild to moderate patient, we have one patient who has the community acquired pneumonia, and initially only 3 to 4 liter of oxygen, and because he was a VVIP patient, so we have used it Aviptadil in mild ARDS patient, and he was successfully uh, uh, improved over the period of time, and no requirement of any HFNC or NIV or something. Yes.
Yeah. So, but special request to everybody who's using this drug, please, if it's a non-COVID ARDS, take a separate consent from the patient. Particularly if it's a VVIP patients, these are the first guys who will turn around and bite you. If things don't go well. So I think we always take a separate consent if it is non-COVID ARDS. And I've been after these Zuventus guys because they have to, if it works in COVID-19, I see no reason. And it is a proven track record. It is beneficial record. Pulmonary hypertension, it is recognized. Sarcoidosis, it is approved for. It reduces the pulmonary pressures, artery pressures, right ventricular afterload, it reduces. So right ventricular failure is not uncommon in patients with ARDS. So I think it can benefit from that point of view also. And it is definitely anti-inflammatory, which has been shown, in definitive studies. It reduces the interleukin-6 and tumor necrosis factor alpha concentrations. So I think it does make sense. And primary problem is atelectasis, whatever the reason may be, whatever the etiology may be. So, Dr. Behera, you've been using this drug. What are the dose and rate of infusion we use?
Thank you, sir. Sir, we have used in around 4 to 5 patients of moderate to severe ARDS, sir. Actually, this molecule is coming as a vial which contains 10 ml is equivalent to 150 microgram. So the dose, as you have already described, it is always in an incremental manner to prevent that vasodilation or hypotension. On the first day, we are using this dose of 0.166 microgram per kg per hour, which is roughly estimated to 150 microgram on an average Indian male. On day 2, double of that dose, that is 2 vial. And day 3, triple, that is 3 vial. Then coming to infusion, ours are definitely in some literature it has been mentioned about 12 hours. But in our ICU, we have mixed a protocol. If the weight is less than 60 kg, we are giving it as a 14-hour infusion. If it is around 60 to 90, then 12-hour infusion. And if it is more than 90, as a 10-hour infusion. As you have already mentioned, sir, we are not getting any severe hypotension or flossing in patients, 4 to 5 patients that we have already used. Maybe it will be there, but we have not found any flossing or hypotension as a side effect. That is the usual standard infusion dose that you are using in our ICUs. And coming to role,
of course, also
mixed result as described in group of patients, it is working very good, sir. And in some patient, it is not working. Probably it's better to use in moderate or who are progressing to severe ARDS. But a patient who is on severe ARDS with multiple organ dysfunction, high dose vasopressor, it is not wise to use this molecule. This is my practical consideration, what we have observed in our clinic.
I may not agree with that, because what you need to do is, if the patient is on a high vasopressors or iodotrobes, you just temporarily you need to increase the dose of these drugs.
Okay, sir.
So the blood pressure is maintained. Generally, vasodilatation is not that much of a problem. Give a little bit of fluid and it gets okay. Because it's a vasodilatation and it's a relative hypovolemia. It's a preload which falls. So you take care of a bit of fluid and it gets okay. Really, I hadn't had to do anything major. We use it quite a bit. Also, one of the senior pulmonologists at our hospital is also quite convinced. So between the two of us, we use it quite regularly without any problems. And we use it in mild cases also, because as I said, it is really difficult to predict which way the patient is going. And it doesn't cost very much. I think it's $10,000 or something, the whole therapy. So it is really not that expensive. And 10, 12 hours infusion, that's what you need. It's completely idiot-proof, because dosage is quite simple. 1 vial, 2 vials, and 3 vials over 10 to 12 hours, whatever. It really doesn't matter. In Delhi, we do not have too many 60-kilo patients, unfortunately. But that's what we use. 1 vial, 2 vials, and 3 vials. Any other comments? Any of you who used it?
Have you used this molecule in severe AKI or a patient who has both kidney and hepatic involvement, maybe in severe ARDS with MODS?
See, I haven't used it in an uric patient. But yes, AKI I have used. There is no problem. What will probably happen is it is excreted by the kidney. So maybe it will get a bit further delayed. But AKI, because about 30% of your patients in the ICU will have AKI.
Yes, sir, definitely.
So I think, yeah, so you can, but yes, I have not used it in patients on CRRT so far, but we'll see how it goes. But
Thank you,
the
sir.
patients who show improvement is dramatic improvement. I mean, first dose will show the improvement. Who's not going to respond will not. Very few patients will
Not
not.
response.
Yeah, but the first, otherwise, how you physiologically improvement, PF ratio, most patients I could estimate in 4 or 5 days time. So I think that worked quite well. And side effects, any of you comments on side effects, other side effects besides hypotension?
So I think
Dhaval?
diarrhea is the most common side effects because the same receptor that is working on this is a VPAC receptor one, VPAC1 receptor, which is in the lung because the Aviptadil almost accumulates in 70% in the lung, and the same receptor is in the GI tract. So diarrhea is one of the common side effects of of this Aviptadil, and hypotension is because you have not seen, sir. I have not so much experience, but flushing, anaphylactic reaction, nausea, vomiting, maybe these are the common side effects, but not so much because there are studies which are not showing any significant or adverse events using these drugs. These are 2 or 3 common side effects.
Sir, is it mandatory to put a central line while infusing this drug, or you can use it through a
No,
peripheral?
it's not. It's not. Because the fluid which you can easily give it through the peripheral line. So if the patient does not require central line, don't put a central
There
line
is no
just for
need to
this.
do it.
Yeah. And generally, hypotension is not a problem. You're giving it over 10, 12 hours. That's why it's escalating doses. And that's why the infusion rate is slow, the 10 to 12 hours. So if you give it instead of 10 hours, you give it in 11 hours, it really doesn't matter that much because it's a prolonged infusion. So it's really not going to. Also, it's an endogenous peptide. So there is no real drug-drug interaction. You're not worried about other drugs which the patient is getting. So I don't think that's also really an issue. It has been used in certain right heart failures also because it reduces the pulmonary, the afterload of the right heart, pulmonary vasodilatation, produces bronchodilation. So that also may help your patient a bit, particularly ARDS patient. So that way it is not bad. Yeah. Any other comments?
Any minimum days for this molecule,
At what
sir?
stage do we administer? We have discussed that.
Yes, sir. So basically,
Sorry?
yes, sir. So basically, we have to use it in the early stage because if you go by the physiology of the drug, at which mechanism drug is working, there is the answer. The answer is lying there. Basically, it's binding the VPAC receptor on the basically type 2 pneumocytes, which is maintaining actually the integrity of the type 1 pneumocytes because there are almost 95% type 1 pneumocytes and only 5% type 2 pneumocytes. So basically, they are maintaining the integrity, and as you are maintaining the integrity of the alveolar wall, so that is automatically decreasing the exudation of the fluid into the alveolus. And definitely, this is improving the surfactant production. This is inhibiting the pro-inflammatory cytokines like TNF alpha and this IL-1, IL-6, this kind of receptor, this kind of pro-inflammatory cytokine reduction. So basically, all these things are actually happening in the first 7 days when the patient is in exudative stage of ARDS. So it's better to use early in the early stage of ARDS when almost there is 7 days gone, or when the patient is going into proliferative phase like the deposition of collagen fiber or the late fibrotic phase. I don't think the drug will work at that point of time. So you have to use it early.
I would agree with that, although theoretically it does reduce fibroblast proliferation. But still, I don't think so there is a point of waiting for it to deteriorate to the proliferative stage because then the battle may have been lost.
Yes.
So I think there is no point really in delaying it. Any comments, any of you?
Sir, just not in the ARDS, but have you used in primary pulmonary hypertension as a vasodilatory pulmonary any?
No, I haven't used it for that, but it does
Okay.
reduce the PA pressures because that particular cardiac patient which I published that report Trally post aortic valve surgery, he had a swan, so his PA pressures did fall. His PF ratio improved, PA pressures fell. So that's a given. I mean, it is a pulmonary vasodilator, it's a bronchodilator, and it's a vasodilator. So that is how these things are effective. So, as I said, that many of these patients with ARDS on high ventilatory pressures would, because of the low lung compliance and high ventilatory pressures and high PEEP, their afterload is already increased on the right heart. So they would have some degree of pulmonary hypertension. And therefore, the right heart can fail in these patients. So this is an additional benefit of the drug. It will help the right heart function. Yeah.
Yes, sir. Thank you.
I don't see any questions from the audience. Anybody, please put it in the chat box if you have any questions. So you basically, as I said, you do not require a centerline to administer the drug. It is a patient, particularly with moderate to severe ARDS, I would suppose you would have an A-line. For mild ARDS, you may not have, but for moderate and severe, one should have. So that is a better hemodynamic continuous monitoring. Yes. Otherwise, I would say that while you are administering the drug, maybe take the blood pressure more frequently if you're non-invasive NIBP in the ICU. So that is where you are. Anything else?
Sir, can I make a comment, sir? Because
please. You have a vast experience, so please do.
It's actually on novel therapy. So there are multiple studies which are going with, you have done with steroids, N-acetylcysteine, prostacyclin derivatives, cibelastat like a neutrophil elastase inhibitors, okay, and pentoxifylline, I think statins, some AC inhibitors, because AC inhibitor also is there in the type 2 pneumocytes, but I don't think there is any studies which have shown some promising result for daily basis use on ARDS, that kind of drug. But there are definitely some things, some new things are coming, like stem cell therapy or natural killer cell therapy. I have gone through a small study, like they have done on, I think, 20 patients kind of thing, and with just a preliminary studies to see the natural killer cell therapy, and they have seen that almost 70% improvement in the treatment group, where is only 10% improvement in the conventional group. I don't think, maybe in future that may have a promising result. And regarding the surfactant therapy, exogenous surfactant therapy, because we don't know actually that the surfactant deficiency, is it a primary pathophysiology of ARDS, or is it something, if some effect of the primary pathophysiology of the ARDS? But definitely exogenous surfactant therapy works very well in neonatal ARDS or the pediatric ARDS cases. But there is no studies showing some promising result with this exogenous surfactant in adult ARDS. Maybe because of some complex inflammatory pathophysiology, or maybe there is an issue with the stability of the surfactant in adult patients. So there is a scope of definitely further research into the exogenous surfactant therapy in adult patient also. But till date, I think only Aviptadil has some actually shows some positive results, but still in India, it's, I think for COVID-19 it is only recommended, and as you guided us, sir. So I was not aware about that, but thank you, sir, for guiding us that we can take a separate consent for Aviptadil for using it for non-ARDS patients. Thank you, sir.
Nicely put together. Also, see what nitric oxide is being used sometimes for ARDS, where pulmonary hypertension is a significant problem, right heart failure is a significant problem. It does improve temporarily, at least, your oxygenation by vasodilatation, intrapulmonary vasodilatation. But again, it's a temporary effect. It is not a sort of curative therapy. And nitric oxide is very expensive. So you have to have the special machine, you have to have the special cylinders, which require. It's very expensive. We do use it at times, but again, it is very temporary effect. Well, whichever patients this therapy works, it works. So I mean, hopefully, you should be able to wean off the, patient from the ventilator. And Medica, as you said, that you use a large, very big numbers of ECMO patients, VV ECMO. But again, it's a bridge. It's just to buy time.
Yes.
The pathology has to reverse before you can't leave the patient forever on ECMO. So that is also another thing which you need to, and obviously the complications of ECMO and the cost of ECMO. I
Yes.
mean, that also has to be taken into consideration. So this is relatively much cheaper therapy without any major side effects, I would say. So I think stem cell therapy, as you rightly said, some few papers with the work is going on. Nothing specific for
Yes.
ARDS really is there.
Hmm.
So I think this is possibly one of the hopes which we have. But yes, we certainly require more published reports on non-COVID ARDS. So I think I would urge these people to do at least start a registry, if nothing else, to begin with, and then they can plan a better study. Because unless some RCT, good RCT comes across, I think people will not accept it.
Yes.
So that is where
Sir, is there any
If
study
you,
available?
I had another comment to make. Oh, sorry for interrupting.
Mm.
Because only
No.
I think there is only 3 RCTs on Aviptadil. I think, but other are only case reports and a case series kind of thing. And if you go these 3 RCTs, so 2 RCTs and the that case report paper is made by a single author. Okay, that Dr. Yusuf and the single author, they have done all these works. And regarding the Indian study, that is a sponsored study, so there is some controversy regarding this use of Aviptadil. But as you said, sir, definitely when it works well. But definitely we need some more research and studies, more good RCTs to establish these facts in cases of non-COVID ARDS, and so that there is a good recommendation on that.
Sir, are you aware of any
See,
literature regarding?
spon-
Okay, sir, continues.
yeah, go ahead.
Sir, are you aware of any literature regarding the role of this molecule in different phenotypes of ARDS, as we were talking about this hyperinflammatory,
No, it has not been.
hyperinflammatory,
It has not been studied that
or pulmonary
extensively. No.
extrapulmonary ARDS? So there is no such study.
So Dr. Sinha has just joined. I think Dr. Sinha is at the airport. Dr. Sinha,
Hello, sir.
hello,
Yes, sir.
hello. Good to see
Good
you.
evening, sir. And I'm extremely
Good
sorry.
evening. No problem. No
Good
problem.
evening, sir.
We are
The
struggling
flight was
to
delayed, and
continue. Okay.
yeah.
So we are virtually finished discussing what it is, but please tell us about your experience with Aviptadil and your thoughts on it.
It must have been told, said that perhaps our evidence is thin, but we are using as an adjunct basically in an ARDS, non-COVID ARDS, where where either my hands are tied down to almost nothing else I am having to offer the patient, and the patient perhaps has said they don't have money enough for ECMO. In that kind of a scenario with a very low PF ratio, maybe less than 50 kind of thing, 2-3 patients we have tried of late. Maybe over the time period, I might have tried 10 to 15 patients, 12 to 15 patients. So the kind of patient profile whom I have tried is basically viral pneumonia. One was a dengue hemorrhagic shock syndrome, and another was a very severe pneumonia, bacterial pneumonia. Those 2 patients, perhaps I would say Aviptadil had worked in the time when there was a need for ECMO, and the patient relatives have said they perhaps did not have money. I don't know whether it is Aviptadil or whether it is the total cumulative therapy what we were giving, but that's what it is.
Before you joined in, we had discussion on this.
Yeah.
Because what we said is, if the patient is so bad that you're thinking of putting him on ECMO, you come to that
Yeah.
stage, that means obviously
Yes,
the severe ARDS.
Yeah.
Then maybe it is a bit too late to use anything. Because maybe the damage is already done.
Yes,
This
sir.
patient may not respond.
Yeah.
So that is what we were discussing. Although the published few studies have shown better results in more severe ARDS, but still I would say we were discussing that why not to, it's not a very expensive drug, why not to start it in earlier ARDS or mild ARDS, because you can't really predict which ARDS is going to worsen. So that is a thing. And obviously, if the patient, I have used it on patients on ECMO also. If the patient is on ECMO, it's not a contraindication, because you see, you need to anyway reverse the pathology. Ultimately, the patient will have to come off the ECMO. So there is absolutely no harm. I have used it on ECMO, VV ECMO. Yeah.
Yes, sir. The point is, sir, theoretically, it works on all the 3-4 physiological parameter where the physiological parameter for which the ARDS is happening. It works on all those 3-4 areas. But practically, it has worked for a few of our cases, your cases and a few of our, and definitely many other people have tried it. But so the point here is the evidence. If we are talking of evidence, perhaps evidence is not so great yet.
Yes, that's why I'm asking, sir. We need some good RCTs to establish it. Definitely, what Sir has also shown the cases. So in certain cases it had worked very well, and maybe in some of our colleagues' cases it works also well. But definitely we need some good quality RCTs, maybe some Indian RCTs, some registry.
Why not we start it? Why not we in this huge number of group? Why not we consider CCI consider a kind of an art city?
Yes, CCI can consider.
No, really. You see,
no, yeah. At least we can collect the data. We can start analyzing the data.
We can have some quality data,
even if it's not an RCT.
Yes.
Yeah. And you can compare it retrospectively with the historical patients. Where you did not use the drug. So a lot of other things can be done, but an RCT requires a lot of not only planning but financial support also.
Yes, true.
So as Arnab, you said that there was sponsored RCT, but now the present circumstances, you are working in a private hospital, I am working in a private hospital. All RCTs are sponsored.
Sponsored, yes, sir.
Because otherwise, who the hell is going to pay for the insurance?
Yes, sir.
Sir, beyond this Aviptadil, is there any role? I have read about the GM-CSF in the particularly hypoinflammatory phenotype of ARDS. Is there any role we can have? Anyone?
See, can I take that?
See,
yes.
No,
please.
Sorry, Dr. Mehta, please go ahead, please.
No, please go ahead. You joined late, so I've done enough of talking.
For ARDS, for years together, since maybe last 40-50 years, hundreds of different drugs has been tried. And if you talk about any of them and everybody of them in a large RCTs have come out as there is no mortality benefit. And even if there may be some kind of a, maybe hypoxemia can get slightly better in some of the studies which have shown, but the mortality benefit absolutely zero. So you can take anything and everything, and you can think that yes, it has shown some response in some studies, but finally it is still we are only at the ventilator management and fluid management and the other ancillary management.
See, if you let me be the devil's advocate here. You all use ECMO quite a bit.
Yes.
I was the president of SWAC also, which is a large body of, I think, covering 40 countries. Okay, I was the president of that few years back. So I believe in ECMO and I use ECMO quite a bit. But where is the RCT which shows that ECMO is beneficial and reduces the mortality?
Yes.
It does not.
No, it has.
The RCT, two major RCTs have failed to show mortality benefit.
At the beginning, sir. Yeah, but
what I say many times is absence of evidence is not evidence of absence.
Yes.
First of all.
Yes, sir.
Now, if you had to show, I'm just off the track just now, but if you have to show that a parachute helps you in surviving if there's a plane crash, okay? For that, half the guys will have to jump without parachute, and half the guys will have to jump with parachute. And then you will say, yes, it benefits. So where the hell are you going to find volunteers who will be ready to jump without parachute? I'm just being there. So not necessarily everything has RCT, and not everything is mortality benefit, because most of the sepsis studies you see are talking about mortality benefit, because you require to do hundreds of to show.
Sir, you have to unmute here.
Yes. So I think that's where we stand. At least we can begin with the registry. Let them collect the data. Somebody will help, should help us to collect the data, and then we can proceed towards the RCT, which obviously somebody will have to sponsor. So that's where we stand. So what I would like to now, I think we had a good discussion. I would like to ask all of you for a quick concluding remark, and then I will close the session. So let's begin with the youngest guy, probably Dhaval.
Yes, sir. Based on our experience as well as your experience and what you have narrated, and all the faculty members have narrated, that it's not a definitive therapy of the ARDS, but definitely it serves as an adjunct in the probably maybe helps in the buying time, or you can have when you introduce into the early stage, then it can help in preventing the mortality and the further damage.
Okay. Dr. Bera, your turn.
Yes, sir. Thank you. So my take would be definitely what I have learned, because I have not used in non-COVID ARDS. So my experience with one single COVID ARDS, and definitely my fellow guys have used in some COVID ARDS patients. What I have learned from you, that I have to take a separate consent and try, at least because the drug has not so much of side effects, we can try exploring this drug in non-COVID ARDS with a separate consent and see what happened in these patients. And definitely, sir, we can make a registry for that and publish the cases. Okay, thank you.
Dr. Behera, you there?
Sir, yes, sir. Sir, just we can use this molecule as an adjunctive therapy in mild, moderate to severe ARDS. In a hope it might work, sir. It's better to have something rather than nothing. We can have a try of this molecule in moderate to severe ARDS. That is my take.
Dr. Sinha, last but not the least. Dr. Sinha.
Sir, till now, perhaps we were not so much conducive towards using it by knowing that it has got not much kind of benefit has been shown in strong, robust manner. But however, whatever smaller works we have done personally, and perhaps some papers have shown, it has got some kind of a benefit. So let's try to give that benefit to the patient. One, it is not costly. Two, it has got no side effects. So why not we be more open to using it furthermore? And obviously we should have a CCI sponsored one RCT with lead being Dr. Yatin Mehta.
Thank you, Dr. Sinha, kind of you. So what, again, I would agree with most of you, that, see, this is a drug which has a scientific basis of why it is going to be effective. Because it increases your surfactant production, it has anti-inflammatory effect, it reduces apoptosis, which has been shown in experimental studies also. It does improve when it works, it does improve the oxygenation. And if it works, then you'll be able to probably avoid further escalation to ECMO therapy or whatever. So if you have to use it, it is very difficult to predict which patient is going to get worse. So I would advise it to use it earlier than later, because, as Dr. Sinha rightly put it, it's not a very expensive drug. And also, it has minimal side effects, and hardly any side effects. So it is a safe drug to use. It has been in the market for a long time for different reasons, for different indications. It is approved as an orphan drug in the US and European community for a long time for other conditions like sarcoidosis and pulmonary hypertension and so on, and COVID ARDS. So I think it has scientific basis. It is a safe drug to use. It's not very expensive. And I think let us all put our minds together and maybe be a little more proactive or progressive, I would say, than what we have been in the past. So with that, I would like to thank all of you, and I would like to thank CCI for conducting this session, and hope it has been fruitful. Thank you very much. Good night.
Thank you very much.